For our group, the first article we had was the effects of implicit and explicit motor learning. And to start us off, we have the purpose of the study. This study aims to assess the effects of implicit motor learning compared with explicit motor learning on walking speed in people suffering from a stroke. The research question for this article is a 3-week implicit motor learning walking intervention more effective compared to a 3-week explicit motor learning walking intervention delivered at home with regard to walking speed in people suffering from stroke? So for some key definitions for us, the first one is explicit motor learning. That is learning generated by verbal knowledge of movement performance. The learner is aware of all the underlying facts and rules of the to be learned motor skill during the process of learning. An example of this would be move your hips to the left and straighten your knee before stepping. Our next definition is implicit motor learning, and this is when the learner progresses with no or minimal increase in verbal knowledge of movement performance and without awareness. Learning is suggested to take place more automatically and is less conscious manner. An example of this would be the PT changes the environment, which changes the patient to walk over a different surface. Verbal instructions are not needed, but the environment facilitates the motor skill. Our final one is the analogy learning. The learning is provided with one single analogy or metaphor that strives to combine all of the relevant rules to the to be learned motor skill integrated within implicit motor learning tactics. An example of this is imagine you are walking over a frozen lake. The summary of this study was a randomized control trial, single blinded. There was 40 individuals per group. The population, individuals suffering from stroke in the chronic stage of recovery, greater than 6 months status post stroke. This study was done to minimize change of improvement from spontaneous recovery. Outcome assessments will take place directly after the intervention and again 1 month later. Use 10-meter walking test and dynamic gait index. Assessment took place at the participant's home, and primary outcome parameter is walking speed using the 10-minute walk test.
So, talking about the significance of the first study that we're discussing today, this study asserts that there are various advantages of implicit motor learning over explicit. And this is referencing previous studies that have been found that participants who learned motor skills implicitly performed the motor skill better under pressure, better in dual task situations, and also better over time. And furthermore, in relation to our population of interest in this article, stroke patients, implicit motor learning has been determined to be of possible additional benefit to those with cognitive deficits, as seen in stroke patients. This is supported by the fact that implicit motor learning is less reliant on working memory stores. So, in summary, this study purports that performance improvements of the patient population undergoing implicit motor learning will prevail for a longer period of time. So next, how does this apply to motor learning? Or sorry, motor control. Um, so just a reminder of what the definition is for motor control. It is the process by which the nervous system coordinates and regulates movements to achieve specific goals. So implicit motor learning is defined as being able to improve automaticity and efficiency of movements in gait. So for example, repetitive gait training can reinforce motor patterns. Next, performance was not disrupted in dual task conditions. So this indicates the ability to free up attention to perform secondary tasks. And then it is hypothesized that performance of movements improvements will remain robust over longer periods of time. And so for explicit motor learning, this helps individuals understand and consciously correct their gait patterns. And explicit instructions can be used to facilitate more precise and controlled movements. And instructions should be tailored to the ability of the patient to process the rules and have the best overall control of movements. And then finally, to conclude for this first study, there is greater benefit in utilizing implicit motor learning and incorporating it into exercise prescription plans. This suggests the concept that it is more useful for the therapist to use minimal to no verbal knowledge of performance as the patient progresses. This will result in learning that is less based on minute-by-minute feedback and helps learning progress to autonomous learning in which the learner doesn't have to consciously think about their actions. So it would be of greater long-term benefit to the learner as well, given that implicit motor learning is tied to longer periods of retention over time.
Okay, so the second article that we read was neuroplasticity in sports injury rehabilitation. So as we know, neuroplasticity is the ability of the brain to change the wiring of neural networks. And there are 10 key principles of neuroplasticity that we'll get into in a second. And having a good understanding of these principles can help us improve rehab outcomes. So first is use it or lose it. And an example of this could be if you're unable to strengthen one limb, you can go ahead and train the other. Use it and improve it. Improve it is training one part of your body and then continue training it for better outcomes. Specificity is not using a cookie cutter rehabilitation program and making it as specific as possible to the individual patient. Repetition matters. It's just performing a lot of repetitions of a task. Intensity, we want to ensure that rehabilitation is adequate and challenging for the athlete. Time matters. We want to start as soon as possible with rehab after an injury or surgery. Silence means that we want the rehab to be motivating and rewarding for the patient. Older athletes may have a harder time and may take longer to rehabilitate. And then transference is integrating multiple sensory inputs during motor learning and encouraging cross-training during rehabilitation. And then interference is when you're working on one set of skills and it may dampen the skill set in another part of the cerebral cortex.
So now we're going to change to the significance of this second article and its application to motor control theories, especially with interventions. So this study highlighted that many current rehab programs that are used for TBIs and CVAs have their roots in the original theories of neuroplasticity. But one common factor for re-injuring, especially with athletes, when returning to sport is a failure to target and retrain motor control. And this can result in aberrant movement patterns in the athlete that is recovering. So the utilization of motor control principles is frequently neglected in rehabilitation, which this article highlights the importance of incorporating those 10 principles into the interventions that you are selecting for your patient, which Erica just touched on. And then athletes also require individualized programs that suit their functional needs and utilize concepts of neuroplasticity. So the clinical relevance and major conclusion of this second article is that having a good understanding of the neuroplasticity principles allows us to tailor exercise programs to each individual patient, and this will improve rehab outcomes. These concepts are important as they are underutilized in our field, as neuroplasticity is a beneficial consideration in therapeutic practice. Thanks for watching.